Hello and welcome back. For our last discussion, we were focused on filtration, that first step of the cardiovascular renal conversation that's going to maintain the homeostasis of the amount of ions, the amount of molecules, the amount of water, and subsequently the blood pressure of our body. We're now going to move on to the next two steps, so the reabsorption and the secretion that's going to be happening in the renal system. And these are pretty important steps because though it is important to filter our blood to get all of that stuff that's in our blood plasma into filtrate that could be eventually excreted, we saw that we filter our blood pretty dysregularly. So pretty much everything in our blood is going to be filtered out into the filtrate. And what we then need to do is make sure that we recapture up to 99% of that filtrate we just created, because a lot of that stuff we just created we actually want to keep. The majority of the water, the ions, the molecules like glucose that we just pushed out into the glomerular filtrate that we just created that will leave the body as urine, we want to recapture it. And so recapturing it is the job of reabsorption. So whereas filtration is primarily pressure driven, so the drive of blood pressure is going to be a big piece, a big facet of how much filtrate is created. The act of bringing that filtrate back into the body is more of a transport type of mechanism. And the kinds of transport that we're going to be doing are both the active and the passive. So if we remember way back to the beginning of the semester, we're talking about membrane dynamics, how things get from one side of a cell to the next, or how things get over a barrier or a membrane of cells, has to do with the kinds of channels that are put into that plasma membrane. And those channels could actively pump things against a concentration gradient, or those things could move passively down their concentration gradient. So how then does stuff move from the filtrate, where it will be lost as urine, back into the cardiovascular system, where it can be kept and used over a cell barrier, so over that cell membrane barrier that we have between the filtrate and the cardiovascular system. So the first thing that is going to happen once that filtrate hits the PCT is the active transport of sodium back into the cardiovascular system, so from the filtrate to the plasma. So we are going to actively transport sodium. And the movement of sodium is super important because by moving sodium, we are going to create gradients that are going to pull other things back to the cardiovascular side. So as we move sodium from the filtrate back to the cardiovascular plasma, this is going to create an electrical gradient. We've now loaded up the cardiovascular side. So we've loaded up the cardiovascular side with a positive cation. That's going to draw negative anions. And we've also created a concentration gradient. We're going to load up the plasma side with a bunch of charged ions that will draw water. So by actively transporting sodium back to the blood, we are going to draw anions. Those will follow because of the electrical gradient. And then once the anions and cations are all loaded up in our plasma, we've now created a very hyperosmotic area. I know using those words probably triggers you again to the whole osmosis and movement of water thing, but hopefully it's pretty apparent that if you've got a super salty side and you have water that can move across a barrier, the water is going to move towards that side that has a bunch of stuff in it, right? So towards the hyperosmotic side. So water is going to move by osmosis. And once water moves, you're going to create a concentration gradient. And after you've created that concentration gradient, other ions, like potassium or calcium, can begin to move because of the concentration gradient. And we'll discuss how that happens on the next slide when I can show you a picture of it. Now, as you are moving these all-important ions, and that is drawing the water back into your cardiovascular system, you've also got in other important things like glucose or amino acids or other organic molecules that you filtered out that you would really like back in your cardiovascular system. We just talked about metabolism. Glucose is super important. So if we filtered glucose out to the filtrate, which is going to leave as urine, we want to make sure we can get that glucose back into our cardiovascular system. And so what we're going to do is, using sodium that we're actively transporting, we're going to do some secondary active transport. And this is going to be done with a channel that's a symport with sodium. So as sodium is being moved across, that concentration gradient is going to drive the movement of glucose with it, drive the movement of amino acids with it, drive the movement of organic molecules with it. So by using energy to move sodium, we are going to help move other organic molecules with that sodium. There's also going to be some passive reabsorption going on here. So things like urea, which easily diffuse across a plasma membrane, these also are going to be distributing themselves back so that they have similar concentrations in the blood plasma and in the filtrate. So these will move by diffusion following the natural gradients that are created, especially when you actively transport sodium or other kinds of cations are moving. So let's look at a visual of what is happening here. On this side, what we have is the filtrate that was just created by the glomerular filtration. Over here we have the extracellular fluid, and you can basically say that anything that makes it here will move back into the cardiovascular system, will equilibrate itself in the peritubular capillaries and come back as blood plasma. So the first thing that we're going to do is we're going to take sodium here and we're going to actively transport it all the way to the extracellular fluid. Once we move a bunch of positive ions over here, our negative ions, like chloride, are going to want to be over here. So there's now this electrical chemical gradient that's going to drive things like chloride through channels or even between cells to be over with its positively charged sodium buddies. Now that we have collected a whole bunch of charged particles over here, now that we have loaded up this side with solutes, water is going to move by osmosis, right? So water is going to move towards the side where there are more dissolved substances. And we've pumped those positives over here. The negatives followed passively. Now we've got a whole bunch of substances, and so water is going to move over to this side. So what's that going to do? You've got this liquid here, and all of a sudden you've got a whole bunch of water moving to this side. As the water moves to this side, it's actually going to concentrate the filtrate after it moves. Think about like a glass of Kool-Aid. If you evaporated all the water out of that Kool-Aid, you would just be left with that super grainy, super solute heavy powder that was the actual Kool-Aid. So as the water moves back over here to equilibrate all of these particles that came over, that's going to increase the concentration here. And now you're going to get high concentration of potassium, of calcium, of urea here within this filtrate. And so these are naturally going to move down their concentration gradients. So they're going to move from the filtrate side towards the extracellular fluid side here. And so just by concentration gradients, these three are going to move down through channels, sometimes between cells if they can, but they'll move down their concentration gradients towards the side where there is now less of them. So first thing we move is sodium, then our anions, the negatively charged ions, are going to follow. Once we have a whole bunch of solutes over here, that'll draw water. That's going to concentrate this area, which means that we'll have a high concentration of potassium, of calcium, of urea over here, and so they will naturally, by facilitated diffusion, some of them, some through passive, some through just diffusion, are going to move towards this side as well. And so in this way, just by moving sodium, we've now moved over a bunch of other things that we also want in our cardiovascular system. Now notice something that's not on here is glucose, that all-important molecule. And there's definitely amino acids, organic molecules, and of course the important glucose that were filtered out into our filtrate. We want those back. We want those back over here into our cardiovascular system. So how does glucose get back? Remember, glucose, big polar molecule, not going to be able to just pop across these cells like these smaller ions and this water can do. So how is glucose going to get back? The exact same way that we talked about in the beginning of the semester when we were talking about the movement of glucose from the intestinal lumen into the blood. So how did glucose get from low to high to low? How did it get across that cell membrane barrier and into our blood and the intestines? The same players are going to be done here. So here what we see is that our old friend SGLT, the sodium glucose transporter, is going to be helping move glucose against its concentration gradient in the beginning with the help of sodium. So this was a symporter that used the high concentration of sodium moving down its concentration gradient to help drive the low glucose, high glucose, so the different kind of concentration gradient. Glucose would not diffuse this way. It would not go from low to high, but it can hitch a ride on the SGLT with sodium that is going down its gradient. Glucose gets secondarily actively pumped into the cell. Now what glucose can do is it can naturally diffuse down its concentration gradient, and it's going to have that GLUT transporter right here. So glucose is going to be able to move from high to low area by going through the GLUT transporter. Now we're going to maintain that high amount of sodium on the outside of cells, the thing that was driving this movement of sodium in, that glucose hitched a ride with, by that sodium-potassium pump. So this is the exact same thing we were talking about in the intestines. We have this situation in which glucose will not diffuse into the cell because there's a high amount of glucose within that cell. So what do? We hitch glucose to take a ride with sodium, which is going down its concentration gradient, and then glucose is able to naturally diffuse through a different transmembrane transporter here, the GLUT transporters, which is just facilitated diffusion. Basically just a hole, and since there's high glucose here, low glucose here, glucose goes here, and we've got it back in the blood, and we are happy. So this is the same kind of secondary active transport that we talked about when we were talking about the intestines. Now, counter to our conversation of filtration, which had to do with pressure, you'll notice that everything happening here needs channel proteins for the most part, not water, but for things like charged ions, for things like glucose, for other molecules, they are going to need channel proteins to move them across that cell barrier because they're big and charged. And so that means that renal reabsorption can reach saturation. So if we remember way back to membrane dynamics, especially the lab that we did, saturation is when a maximum rate of transport occurs and all of the carriers are occupied or saturated with the substance. So basically, all of the SGLT transport proteins here are working. They are moving a glucose molecule across the barrier. And what can happen is you could have more glucose in the filtrate than these transport proteins have the ability to move back into the blood. So if we take glucose, for example, in a healthy, normal individual, 100% of the glucose that you filter out into the filtrate will be reabsorbed back into the blood. So that if a person who is normal and healthy urinates, their urine will have some ions in it, sure, but it shouldn't have any glucose in it. So the healthy urination won't have any glucose. But what about a situation that is out of homeostasis? So in the disease diabetes mellitus, what you basically have is an excess of glucose in the blood. So this means you're going to have an excess of glucose in the filtrate as well. Remember, the filtrate is basically just the blood plasma. So you filter out more glucose into your filtrate, and you haven't increased the amount of SGLTs. That's just not something that can happen to the same rate that you've created glucose in this disease. And so basically what you now have is an excess of glucose in the filtrate. And so you can't bring back all of the glucose that you distributed into the urine. And that means that your urine is now going to have some glucose in it. This is called glucosuria, glucose in the urine. It's one of the ways that we can test the urine of an individual and begin to make some diagnosis of that person. If there's glucose in the urine, there's some kind of issue with reabsorption of glucose, because in a normal, healthy individual, you're going to absorb 100% of that filtered glucose back into your blood plasma. So there's some kind of issue if you do find glucose in there. And the reason that you would find glucose in there is because reabsorption is an transport mediated process. It requires channel proteins to move stuff in a particular direction, and those channel proteins can basically be overwhelmed if there is too much substrate to move. Now, the final thing that I would like to talk a little bit about is secretion. So secretion is the final step of this conversation with the cardiovascular system and the renal system. And, in fact, we'll pick up secretion and the overall movement of different ions in the next video. So let's just focus in here on the absorption.